This is a little bit easier.
I'm recording, by the way, so we can send it to others. All right.
That's fine.
As I said, without further ado, Heather Suri of Pathways in Aging, thank you for being here this evening. And Dr. Mansbach, who works with Counterpoint. So take it away.
Sure. And hello, Dr. Mansbach. Good to see you again.
Heather, I just talked to you last week. It's great to be able to see, well, sort of see you. I can see the cave for Kensington. So I'll do the best I can, pretending like I'm talking to people.
There we go. I know. Well, we're gonna fake it. We're gonna do great here. So thank you for coming. I wanted to just check in quickly, and then I'll tell you a little bit about me and what I do, and I'll invite Dr. Mansbach to do the same. But who knows what an aging life care manager is? Okay. couple people I know really well, and someone I probably need to know. So just real quick, because that's what I am. I am a nurse by training, but I am an aging life care manager, and I own a practice called Pathways in Aging. And aging life care managers, we've got about 2,000 of them in the country. We've got about 200 in the Mid-Atlantic. The Aging Life Care Association is our professional association, and we're a collective of half of us are nurses, half of us are social workers, and then we've got a sprinkling of other professionals from other health and human services background. And we coordinate care. So we can act as professional advocates. We act as team builders to help people find the right in-home services, the right doctors, the right resources in the community. We work with every family a little bit differently. But one thing that we all have in common is we all have a high level of expertise in aging, a pretty broad knowledge base of all things having to do with aging. So that's what a care manager is. And I practice here in Northern Virginia, and I also have an office in the Seattle area. And I've got a fantastic team who works with me. And what about you, Dr. Mansbach? Let's hear about you.
Okay, well, I'll be relatively brief, so we can get on to the content of the program. So my background's in geriatric neuropsych. So I'm very concerned with dementia, memory issues, and all the psychological and psychiatric issues that can come with that. I run a company called Counterpoint Health Services. We provide psychiatric neuropsychological services to residents in senior living and nursing homes in the community. It's a large group of about 80 or 85 providers. I am the director of the BCAT Research Center. So we create cognitive tools that other doctors, other providers, really across the spectrum use to identify what's going on with a person cognitively. I know that Heather Suri, who's with you in person, apologize that I am not, is very familiar with BCAT and uses it really well and in a very integrated way. So I do research, I do clinical practice, I manage a pretty large healthcare group. I write books, I try to be a resource, and tonight I'm a resource for you. So hopefully Heather and I can answer any questions that you might have.
Thank you so much. And the BCAT tools, that's something that's worth writing down and looking up. The bcat.com, fantastic resource for families as well as professionals like me, but there are some wonderful evidence-based tools that you can use at home or with your loved one.
BCAT?
It is, yeah. So I wanted just to take a quick pulse check here about what we want to talk about tonight, because Dr. Mansbach and I are kind of ready to talk about anything. Who here has a loved one with cognitive impairment? Just about everybody, Dr. Mansbach. So
I believe it.
So I think, initially I was thinking maybe we would talk about depression and anxiety in general, and we can talk about that. But it seems like if everyone has a loved one with dementia or cognitive impairment, do you have specific topics? Are you concerned about behaviors are you, yeah, okay. Anxiety, okay, okay.
And how that can be managed if aggression kicks in because
Got it. Okay, so some of those challenging behavioral expressions like agitation, aggression, talking about anxiety.
And also how to respond, so in my case, it's my mom, and she confronts increasing issues of whether it's delusions, confusion, spatial, how to be able to be supportive and responsive when a lot of, we're not supposed to push back, but then how
Right.
do you deal with it? Right.
Right, right. So confusion, delusions, how do we support without making it worse? Right? And maintaining your own sanity in the process. Yeah. What else?
hallucinations, disorientation.
Okay, hallucinations,
What I
disorientation.
want to say is what happens when I don't see my family member? With me, he's relatively the way I've known it.
Okay,
And I don't know how he is other times.
other times. Okay, so you're concerned that there might be a change in the behavior when you're not there.
Well, how to support him when he's upset when I'm not around.
Oh, when you're not there to help de-escalate or whatever tricks that you know inherently how to help him. How do we help when you're not here? Alex, you had one.
Yeah, what is an appropriate time to introduce medications?
Okay,
So, just being able to understand, redirection and things like that, but also when is it a good time to introduce,
so looking at that kind of that whole spectrum, or I talk about it, the tools in the toolbox. So our non-pharmacological tools and our pharmacological tools and how they work together and when we should consider medication. Yes.
I have a much more basic question, which is when you first encounter this dementia, you see a neurologist.
Yep.
And he says, oh, this is dementia, take Aricept and all that. And
Yep.
come back and see me in 6 months and
Right.
1 year. And over the years, I've not found neurologists that useful.
Yep.
So who do you see who can say, yeah, I've seen this problem. This happens with dementia. I just am unclear of who your doctor
Who do
should-
they see for comprehensive care for people with dementia, Dr. Mansbach? Maybe we'll get to that.
Sure, sure.
So I think, maybe the question that Alex asked about, again, the medication and bringing me back to this tools in the toolbox. I think that's a good place to start because there are a lot of non-pharmacological tools that we can use to address some of these. So let's talk about that. What are your go-tos? Where do you help families start when they're noticing anxiety, agitation, aggression? A lot of times it gets worse throughout the day, maybe worse toward the end of the day. Where do you start with things like that?
Do you want me to go ahead and start with?
I do. Yeah, I know. I'm looking right at you, Dr. Mansbach.
Yeah, but all I see is a K, so I don't have any visual feedback. It's kind of like dementia in a sense, if you think about it, because you were robbed of certain cues that actually prior to dementia you were able to respond to. So you'll have to just keep that in mind, Heather. So
I will.
These are all really good questions, and so we'll start to address them. I'm sure our answers will clarify some, but also create other questions as well. I suppose I start with describing the cognitive continuum that actually, as we age into different levels of, unfortunately, cognitive decline quite often. So, we start with normal cognition and we tend to progress to sort of pre-dementia syndromes. We call them MCI, mild cognitive impairment. But as we'll probably talk about tonight, it's not mild, it's not benign, but it's not dementia. And then things progress to dementia. I think I would point out that dementia is by its nature always progressive. If it's reversible, it really isn't dementia. And that's the case if we are talking about Alzheimer's disease or vascular dementia, Lewy bodies dementia, frontal temporal dementia, any of the 11 or 12 illnesses or diseases that actually cause dementia, I would probably say that dementia is the result of a disease such that it's like a cause and effect. There must be a cause, a genesis for why a person has dementia. That dementia is really a syndrome, a collection of symptoms. We most often think about Alzheimer's disease since it's the most common cause of dementia. And then I probably would start talking about what we can do, just as Heather pointed out, pharmacologically in terms of medications, and what we can do non-pharmacologically, which I have to say often is more effective, believe it or not. And then when we talk about medications, I would probably say we need to divide them into categories. Medications we use for primary memory or cognitive issues, which don't work very well. And then I think I would talk about the other kinds of medications that we use for, I think it was actually mentioned already, agitation or depression or delusions or hallucinations. So let me just stop there and invite you, Heather, to add to that, and then maybe we can get more specific as we go along.
Yeah, well, I think that when I'm working with a family with someone with cognitive impairment, usually when we're seeing some of these symptoms, my first approach is always to look at potential triggers, right? And some can be, we can talk about the common culprits. Some can be environmental. We can see people have trouble with too much stimulation. And we can have people who struggle with too little stimulation or the wrong kind of stimulation. Another thing that we look at is routine and structure. People with cognitive impairment often are more comfortable and have less anxiety when they have a structured routine to participate in. And then another one that I'd love Dr. Mansbach to talk a little bit more about, because this is something that that I use so much, and quite frankly, I really learned more about it working with the BCAT team, but talking about communication and how the ways in which we communicate with people with dementia can help or can make things worse. And I think as a nurse, I kind of knew what worked and what didn't work from years and years and years and years of experience. But Dr. Mansbach, his research and his team really helped me to understand some of the brain-based reasons why some of these things work. So I'm thinking of those 10. Is it 8? No, it's the great 8.
Yeah, no, that's good. So why don't we do this? Let's talk about what we call the BPSDs. These are really behavioral and psychological symptoms of dementia. You would think about them as physical aggression, verbal aggression, delusions, hallucinations, things of that sort. Because if we think about them, we know that for people who have dementia, about 80% of them in any given year are going to have some of these symptoms. So they're really very common. And these are usually the things that we try to treat, either behaviorally without medications or with medications. But one thing that we should always keep in mind is that at least half the time when we see these things, like, let's say, aggressive behavior when you're trying to provide care in some ways, about half the time, these are caused by us. The term is iatrogenic, which means caused by us, agitation. So we created something called the Great 8 communication tips. And I would recommend that as family members, you get this, we put it on a PDF or just a piece of paper front and back, and to keep them in mind, because if you manage these behaviors, these forms of communication the right way, agitation is much less likely to occur. Conversely, if you don't pay attention to them, things are going to get worse. And we can go over them today. And Heather, I think in order to do that, we should probably spend even a minute on working memory, because that explains why these are effective, I think, at the level of the brain.
Yeah, I would agree, and I have been to your talks before in talking about working memory. So working memory is that part of our brain that helps us remember when we get to the grocery store that we wanted bananas, milk, and sugar, right? Tell more
Exactly.
about that.
Yeah, so we have the working memory requires us to pay attention long enough to learn something new. And for people who have, let's say, normal cognition, normal memory, we have about 30 seconds, sometimes a little bit less, to begin to make a new memory. And if we wait beyond 30 seconds, then we can't make this memory happen anymore. And if we have dementia, it might be 5 or 6 seconds. And why that's important is that if you have a loved one who has, let's say, moderate stage dementia, her or his working memory might be 5 or 6 seconds. So if you're talking to him or her and you're using sentences that have more than 5 or 6 words, you're exceeding your loved one's working memory, and they're more likely to get agitated. And Heather, why don't we illustrate this in this way? Why don't we ask the group to memorize, without writing it down, a phone number, and no one has to have any worries because no one's being tested here, right? So if Heather gave you a phone number, it would have 10 digits, and let's suppose that she told you each digit might take about 1 second. So she can tell you this in 10 seconds or less. And if you started to remember it right away, you'd probably be able to do it. So we're going to do that. And then I'm going to do it a little bit differently and show you what it's like to have dementia. So Heather, do you want me to say the phone number, or do you want to just say the phone number and then ask everyone as a group to repeat it?
Okay, yeah, I'll do that.
Okay, you can make it up.
Okay.
You
All
have
right.
to remember it too then.
The phone number is 571-303-6942.
Okay, group, what's the number?
571-303-6942.
That's pretty good, I have to say, particularly at the end of the day. I have to tell you, I've done this exercise all over the country for every group imaginable: nurses, rehab therapists, physicians, psychologists, and everyday people. And you did just as well as anybody does. So that's good. And it's a good thing I said that, because the next thing I'm going to ask you to do is harder. So this time, Heather's going to give you a new phone number. And before you repeat it, I want you as a group to say out loud the number 100 and count backwards by 3. And we're gonna let you do that for 30 seconds, and then we're gonna ask you the phone number. And besides the area code, which is easy to remember, I bet you'll have trouble. So Heather, if you can come up with another phone number.
I was going to say they're already doubting their abilities here.
Yeah, but you have to know what it's
You
like.
gotta
So this
have
is
the experience. Okay, guys.
this is empathy training, right? So let's go ahead and do this. Heather, you lead the way.
Okay, the number is 703-652-8972.
Okay, all together, and I'm looking at my watch. 100, 97, 94. I don't hear anyone. 91, 88, 85, 82, 79, 76. It's getting harder. 73. Well, we'll just stop here to spare. It's like the mercy rule, like when you're a kid and you play in a baseball game and your team's behind 15-0, they just stop the game. So we'll stop it here. What's the phone number?
Six,
9.
2. And that's as far as I'm going.
Okay, so what this illustrates is this is what working memory is like. So if you have working memory for 5 or 6 seconds, it's very easy, right, to become overwhelmed by information, which is important that if you're talking to someone whose working memory is only 5 or 6 seconds, that you use sentences or phrases that only have 4 or 5 words. You don't want to use very complicated language, because it's more likely that a person can't remember the beginning of what you said, right? And that leads to agitation. And the Great 8 communication tips are all about that: how to say things or how not to say things such that a person doesn't become agitated. So we'll make sure that we give you a link or how you can actually get a copy of the Great 8 so you can use it whenever you'd like.
Awesome. Okay. Did you have a question?
No.
Oh, okay.
Question.
So let's see here. So we talked a little bit about how we can try to identify and minimize some of those triggers. And I am a big believer in, most of you are probably familiar with what we know of as sundowning types of behaviors. And I'm a big believer in that, if we can really minimize all of those things during the day that create that anxiety and that agitation buildup, I do think, and this is anecdotal, he's the researcher, but I think it does help with some of that sundowning behavior.
I would agree 100%, Heather. I mean, it's sundowning or late day confusion is pretty common. I could tell that people are pretty familiar with it, and so a person just has less of a stimulus buffer. It doesn't take as much to kind of overwhelm a person, make a person seem agitated. The interesting thing about sundowning or late day confusion is that it's not just about sort of the period between, let's say, 2 in the afternoon and 8 o'clock at night, which is kind of when you normally see the people becoming more agitated. Whether or not a person's going to have sundowning actually involves the entire day. How much sleep did they have the night before? How much stimulation did they have prior to, let's say, the late afternoon? So as Heather talks about identifying triggers, it's triggers during that 2 to 8 o'clock period, but it's also triggers that happen earlier that a person's just been absorbing all day, and then they get to a point where it's the final straw. So it's kind of the whole thing. So Heather's someone, for example, who can help you identify, well, what's really going on during the day that could, where you can improve that situation.
So let's say we're in a situation now where we've done our best to minimize all of those triggers and to manage the anxiety throughout the day. But now it's the end of the day, and your special someone is really not happy. They're frustrated, they're agitated, they're worked up. What do you do when somebody is already in this escalated state? I got some ideas, but you want to start with a couple ideas? We've already got somebody that's already escalated. What should be one of our first go-to actions?
Okay, so often people think about medications first, and I would say that they should be considered second or third, but not first. So if you can't prevent an agitated behavior from actually happening, depending on what it is, so it could be verbal, or it could be physical, or could be any sort of type within all those kinds of things. The first thing you really want to do is quiet the situation down as much as possible, and I think about it as a kind of like as a temperature gauge. If we have a scale of, think about it from 0 to 10, and somebody's at a 10, you're not trying to move them right away to a 1 or a 2. You're really trying to move them to a 9 or an 8 first. And there are a couple of ways that you can do it, actually more than a couple of ways, depending on the person and the environment that they're in. It could be removing them in their immediate vicinity to a low stimulation situation. It could be reducing the lighting intensity that's in the situation. There are actually a whole list of things. Some of these, I think, are items that Heather probably does before you consider medication. So let me stop there and invite Heather to contribute, and I'm happy to come back and talk about it again.
Yeah. So the first thing that I coach caregivers to do is you got to do a self check-in. That's the first thing. You got to take a deep breath and let it out over 3 seconds and try to help some of that tension come out of your body, because we know that when somebody is agitated and escalated, we start doing it too. You know, our shoulders get tense and our face gets tense and we start to get anxious, and that isn't going to help our person calm down. If we're escalated, we can't help them de-escalate. So I think that's step number one. You got to do a self check-in, and you know, in the time it takes to take a deep breath and let it out, try to release some of that tension. Definitely, if there are things that we can do to change the environment to help it be more comfortable for that person, sometimes bringing the stim down works. You know, the other technique you all probably know about redirection. You know, sometimes helping someone to shift gears. You know, I sometimes, and it depends on the person. It depends on where they are in their dementia journey. But I think that reminiscence can be really powerful. And it also depends on how escalated they are. But sometimes talking about or recalling a story or asking them to remind you of a time in their lives, and if you have a loved one with dementia, they probably spend some time during this time, right? We see people kind of go back to that time in life where they felt powerful, where they felt kind of most like them. See if you can start eliciting a discussion or a memory of that time, and sometimes that can kind of bring things down. You know, sometimes sometimes it's making a cup of tea or a cup of hot chocolate and just kind of sitting down and offering something normal. See if that's a way, you know, when I say normal, by it like a normal activity, because when we've got this escalated behavior, nothing feels normal. So sometimes when, you know, we kind of slip back into a routine, it helps them come back to the routine also. You're not going to talk them out of it, and you're not going to be able to challenge whatever reality they're in during that time. That is, you know, almost universally makes things worse. When we have someone with dementia, we have to step into their reality. You know, it doesn't work for them to try to bring them into ours.
So I think those are all really practical and good suggestions. Let me just add a couple things for you to think about, and that is people generally, there are exceptions, but generally folks who have dementia don't go from 0 to 10 in a heartbeat. It may seem that way, but there's usually a ramp up period. So you want to intervene obviously before you get to a 10. If you can intervene at 5 or 6, you're much more likely to calm someone, bring someone back down again. So that's important. Secondly, you should always know, as walking around knowledge, what we refer to as a calming object or a calming phrase. So if a person's at a 6 or a 7 in intensity, not at a 10 yet, what can you give them? What can you say that might actually redirect them and calm them down? Sometimes it's a photograph of a loved one. Sometimes it's a phrase. I talked to your daughter yesterday. You have to know what this is ahead of time. So when our team comes in, for example, to evaluate someone with dementia, one of the things that they're instructed to do is find out what a calming object or phrase is, and they're unique to the individual because you may need to use them. Using them when somebody's at a 10 level of intensity, it probably won't work. And so getting better at noticing the signs of agitation are key. And Heather, maybe we can talk a little bit about tonight how you really can tell, and I think we miss the signs. It's normal for us to miss the signs, but they're almost always there.
Yeah, I think, and sometimes they can be really individual, and caregivers get to be experts in their own person, and what those signs are. I just wanted to jump onto something that Dr. Mansbach made me think of when we're talking about, trying to intervene or help when someone's out of 10. Medication doesn't work when someone's out of 10 either. I mean, they have to actually take the medication for the medication to work. So, trying to avoid that high level escalation is really critical. So it comes back to seeing the signs. So, I can think, again, I know Dr. Mansbach's got some research in his back pocket he's going to share with us about probably some common signs that we see, but I think of restlessness. I think of maybe rumination, getting kind of fixated on something specific. Early signs. What do you see in your loved ones as an early sign that things are going south, that they're getting frustrated or anxious or agitated?
Movement of a right hand.
Movement of the right hand. That's really specific. Okay.
Right.
Yeah.
Tired, not enough sleep.
Tired, not enough sleep. Okay.
Fixated thing. I
Yeah.
see that.
The fixation, getting fixated.
Perseverating.
Yeah, the perseveration. Okay.
Teariness.
Teariness. Okay, so some emotional lability maybe. Okay. What do you think, Dr. Mansbach?
I think that you're all moving in the right direction. It is individual. It's almost always behavioral and observational. If you really think about it, you can come up with one or two things for each person that are telltale signs. And I'm reminded that it's a painful. I think sometimes it's a painful thing to talk about, but there is a tendency for family members to stay too long for visits. That the window of time is different in a dementia mind than it might be for the rest of us. And so this can happen when you first move somebody in. It can happen throughout. And remember, dementia is progressive. So what might be the kind of condition of the day today may look very different in 6 months or 8 months or a year. So time feels different when you have dementia than when you don't have dementia. Shorter visits, less going on, calmer. And I think that there's a
disruption of the routine, I think,
yeah.
Yeah.
Yep, all those things are important. Again, most, but not all, certainly half of agitated behavior is preventable. So we have to ask ourselves, well, what are the signs that we have to pay attention to? And what do we need to do to reduce agitation? And you have the power of doing that, just as caregivers, professional caregivers have the power to do that.
So let's talk a little bit about medication, because I know that's something that folks are interested in. How do we use medication as a tool appropriately, kind of managing that, the risk of potential side effects versus the benefit? I mean, I know it's different for every individual, but what kinds of considerations are we keeping in mind when we're making those decisions with our doctors?
I think we should divide the medications into medications that are used for memory enhancement versus the other psychiatric medications, because the first group, in theory, is to help with memory and primary cognition. The second is to help with the associated, symptoms that we see, like problems with mood, delusions, hallucinations, things that people have already mentioned. So if you already are at the point of dementia, the memory, there's virtually zero empirical evidence that these medications help with memory. They may help in other ways, but so if you have a diagnosis of Alzheimer's disease, the likelihood of a memory enhancer, a cholinesterase inhibitor like Aricept, or a glutamate medication like Namenda, it's very little evidence that they work, unfortunately. So, and there's no such thing as a benign medicine. So if you swallow something, it's in your body. Now, that doesn't mean that they're always terrible. It just means that you have to be careful. So I'm thinking about the gentleman that made the comment about you go see a neurologist. Neurologist does, a brief little cognitive screen, says, I think you have Alzheimer's disease. You may or may not have an imaging study like a MRI or fMRI or a PET scan or something. And then, the drawer opens and the idea is Aricept or something of that sort. I think we have to be really honest with people. And one thing I can recommend for you is at BCAT, we have this free interview series called Family Matters, and any of you can access it. So we can give you a link for that. And we invite some expert in the world to talk for 30 minutes. We interview on some topic, and we had Dr. Susan Lehman from Hopkins Geropsychiatry Service talk about what works and what doesn't work with these memory enhancer medications. So I would suggest that you listen to her, because she's quite a good clinician and a good researcher, and that may be helpful. So Heather, anything you want to add to the memory enhancers before we talk about the other medications?
Yeah, I think that's, that's our experience as well. That, especially when the dementia progresses to a certain point, then we've just got a whole lot of polypharmacy anyway, right? People are on all of these medications. We want to make sure that whatever we're offering is offering some benefit and not creating an unintended side effect or mixing with things. And I think, I get, as a care manager, a lot of feedback about experiences with neurologists and that kind of diagnostic process, which sometimes can feel limited. And it's like, okay, and this is just my perception, but sometimes I think it's kind of what they can do. They've given you this diagnosis, and they've given you a prescription, and that's what they can do. And part of it is that because they don't know always about all of the resources out there. And unfortunately, the way our medical system is really built around what insurance does and doesn't reimburse for. So they also don't have the time to gather all of that information and spend the time with you to help you understand what else is out there to support you and your loved one with the new diagnosis. So yes.
So Heather, maybe it'd be helpful. Let me ask the group. We can share with you what we think should go into a dementia workup.
I think that's good, but we have a one question I want to address first. We had a hand raised.
Sorry, I didn't want
Great.
Thanks to the internet, we are all medical experts these days, right?
Yeah, right.
So I've sort of studied a lot about this Aricept, and and the general consensus is what you say, the memory. But there seems to be some reasonable body, including Cleveland Clinic, that talk about withdrawal effects. That in fact they might, so what I took back from that is don't withdraw unless you really are having problems. I don't want to divert you.
No, that's interesting. So I don't know. Did you hear that?
I think I did. I think the issue is, and tell me if I have this wrong, that there can be issues with withdrawal or gradual dose reduction of a medication like Aricept that can lead to problems for the patient. And one alternative is if the patient's doing okay, not having side effects and so forth, don't withdraw the medication until there's some sort of physical problem. Is that or
Thank you.
mental problem? Is that right? Yeah.
Yes.
So I think I actually don't share that view of the science. I think that there has been two things that have been reported in the literature. I mean, one is that withdrawal of medications like Aricept can be tricky, but a careful gradual dose reduction over a long period of time usually corrects that problem. So most people start on 5 milligrams of Aricept, they go to 10, or it depends. It may be different depending on if we have some sort of time release way of approaching this. But generally, so you're starting your withdrawal from the highest dose. I mean, that's generally what happens. And so quite often, physicians just take people off of them. And Heather, I'm sure you've seen this many times, where that's a shock to the system. So I'm not sure that I support the idea overwhelmingly that you should just stay on a medication, because I think that there are side effects that you don't even see in some of these medications that are additive. The second item that's been reported in the research literature is this, that whereas there's little evidence that Aricept is helpful for cognition, it might help with function, like memory of where the dining room is or something of that sort. But once again, I think the majority of the studies don't necessarily support that. So that's my view on it. It's just one view on it. There are other views on it. You should take, any one view in consideration of others, but that's kind of how I think about it.
Okay. I would love to have Dr. Oh, you have a question, Alex?
Yeah, well, I can wait.
Okay. Well, and I might get to it. So I'd love to talk about what, and I will definitely share Dr. Mansbach's perspective on what should go into a dementia workup and how they do it at Counterpoint. But and then after that, I want to talk about the other classes of medications that
Yes.
probably people are familiar with, the benzodiazepines, the atypicals, the things that we see often prescribed to manage some of these symptoms.
Great. So we put a lot of thought into what a dementia workup should be. And what I mean by a dementia workup is you have a loved one and they seem to be having some symptoms. Maybe a person's not remembering things in the same way that they used to. Maybe they get lost when they're driving somewhere. The stove doesn't go off when it's supposed to. Just some indication. It's usually intermittent in some ways. And here's what we advocate. So we have a center in Maryland called the Brain Health and Psychiatry Center. It's actually in Columbia, and we try to make this interprofessional. So when you come to this center, you see 3 different providers to try to figure out what's going on. And we usually recommend that before you come here, that you go online to a website called enrichvisits.com, and take a cognitive self-assessment. And if your loved one can't do it herself, assist them. It's fine. Called My Mem Check, because it was created for this very purpose. It's free, doesn't cost anything. It's not a diagnostic tool. It doesn't say you have Alzheimer's disease. It just says whether or not it makes sense to have a professional evaluation. So it's called My Mem Check. Now that's assuming that you're not working with an aging life care professional like Heather, who will already know to go to the next step, right? So, but most people don't have the benefit of working with Heather right away. So you take something like My Mem Check, and it may indicate that you need a workup. So we think these are the components of a workup. when you come in, a cognitive screening tool, like just a screening tool, you may have heard of some of them, like the MoCA or the SLUMS, or the
Still using
MMSE.
MMSE everywhere.
Yeah, MMSE. Yeah, those are okay for an indication, but you can't make a diagnosis based on those. What you really need is something called neurocognitive or neuropsychological testing. And we do a geriatric battery, although painfully, we start people much earlier than the geriatric years. I say painfully because we start people usually at 50 for this battery, although we can see people who are younger. That's certainly not geriatric. Many of us are well beyond that, so no offense to anyone. But the neurocognitive or neuropsychological battery, they're interchangeable terms, is really important because it's very accurate in identifying if a person has dementia, where they might be in the process. It looks at very specific cognitive, what we call cognitive domains: memory, executive skills, that would be sort of like the control and command center of the brain, the ability to organize, sequence, and plan, and all that sort of thing. It looks at certain functional things. Can you still, do things like balance a checkbook and a whole bunch of stuff like that? So that has to be in there. Secondly, we think it's important to have a psychiatric evaluation. So you'd see someone from the psychiatric team. So now you have neuropsychology and geriatric psychiatry working together. And then we prescribe maybe no medications, maybe so, but we also prescribe, based on a person's cognitive abilities, very specific working memory exercises to try to improve cognition and memory, but also to try to slow down decline if the person already has dementia. And very often we make a recommendation, if someone's living in the community, to work with someone like Heather. That's not what we do, right? We do the evaluation, and we can treat, certainly, but there are a lot of life decisions that have to be made where you really need an aging life care professional to kind of help in that. So if you don't go to a place like ours, you can still get it done, but it's piecemeal. You have to find a neuropsychologist to do the testing. You have to find a psychiatrist or a psychiatric nurse practitioner who does geriatric dementia work. It's all doable, but it's a little bit more complicated. So that's kind of an overview. It's important. And the last thing I'll say is an evaluation must also evaluate the supportive needs of the caregiver, because if you don't do that, you're missing a really important part of the picture. Okay, I'll stop there and hand it over to you.
Yes.
So if you were to look for a psychologist, for the neuropsych testing, or a neuropsychiatrist, is there a directory? Is there somewhere you can go on the internet to find a directory of where these people are? Because I get asked for these and I'm having trouble finding.
I haven't found a directory. There's just some different practices. And usually the way that I see things go, people see their neurologist because they're concerned, or maybe they've seen their PCP and their PCP says, go see a neurologist. And then they have you draw the clock and they say, yeah, there's a problem. Here's your prescription.
Yeah.
Other things, even before we get to Dr. Mansbach and the neuropsych testing, it's also good to look at other possible medical reasons for the change. Like, I like to see some imaging. I like to see some blood work. Let's really rule out potential medical underlying causes for these cognitive changes before we get too far down the dementia road. And then in terms of the neuro psych testing, you can always start with the medical systems. Inova.
Ask me.
Okay.
No, I'm serious. We have some people that I can refer to because I get asked, but they're booked out months in advance.
Yes. No, you're
there's a shortage of experts, Dr. Mansbach.
Yes.
Yeah. I mean, it's a painful situation because there's a shortage of experts across the board, not just in neuropsychology, but geriatric psychiatry, painfully, even, in nursing as well. But, you can start with your primary care physician, and you hope that this is a person who can, get you started, be encouraging, and then give you some names. Sometimes the state associations, I know that in Maryland, and I think in Virginia, there's a resource guide online where you can look for a neuropsychologist, for example. And they fall into two categories: those who work with kids, the pediatric ones, and then the geriatric ones. So it's a small pool of people, unfortunately, and it is kind of hard to find them.
And a 3 to 6 month wait for that comprehensive battery in the community is not uncommon. The other thing I'll tell you, I mean, aginglifecare.org, we've got people like me all over the country, and we know who can get you in the fastest, who bills insurance, who's really good, doesn't bill insurance, but is worth the out-of-pocket expense. I mean, we can provide those types of resources to save like hours of research. The access to these types of services for older adults is extremely fragmented. So it's, that's something that my discipline is really good at. And at some point, Doctor, you will have a center in Virginia, right? Didn't you make me that promise last week?
I did. Northern Virginia. I think someone in the group and you, Heather, also pointed to kind of ruling out other things other than dementia that may contribute to some of the cognitive symptoms. And believe it or not, the most common one is depression. So there's a condition called pseudodementia. It just means that people with significant depressive symptoms can get confused. They can have memory issues, attentional issues. I can explain what happens in the brain. If you want to go to sleep, I can explain what happens in the brain that makes that happen. But more importantly, ruling out depression is key in all this. And even if there are cognitive issues, depression really makes it that much worse. So one of the things that you'll find on the Enrich website is something called the Enrich Calculator. Again, this is just a resource for families. And it's a way of identifying risk variables for dementia. But one of them is about mood, about depression in particular, and stress. So Heather, at some point we should also make sure that the group is aware of the M5 for stress, because caregiving is stressful. Being a family member of a loved one with dementia is really stressful. And how do you know when you've had too much? If you make it subjective, it's not the same thing as an objective standard. So the M5 or the Mood 5 is kind of a place where you could go to find out.
And that's on at the BCAT.
Well, it's actually on the Enrich website, enrichvisits.com. Yeah. And that's a free tool too. And we developed that, actually published that. We were asked to do that during COVID, actually, because there was such a concern that the anxiety that goes with COVID is, it's horrific, but there was no tool that was specific for a COVID situation. So the M5 first started in that way, but it's a good general kind of, we call it a stress temperature, instrument in some ways. So yeah, enrichvisits.com.
Yeah.
Can I do that?
Alex, you had a question.
Yeah. Can you tell us, both of you, since there's such a negative stigma just around seeking out therapy, when is a good time for a family member to seek out Jerry psych services? So I feel like, we talk to families about that. Family members will say, I'm not ready for that, or I don't feel like it's necessary. So can you kind of speak a little bit to that?
Yeah, so dealing with the stigma around getting help. Doctor might be frozen here. Okay.
He's
I
tired.
can I can talk. Let me know when he starts moving again.
Oh, I'm back.
Oh, he's back. Okay. Okay. So stigma around seeking services and how to talk to families and individuals when, when we might notice either as professionals or family members that there's a problem. How do you have that conversation without making somebody feel like you're telling them they're crazy? Because that's the first thing they say, right? I'm not crazy. I don't need to see a psychiatrist.
You're good.
Go ahead.
Yeah, that's a really that there's a lot to unpack in all that, right? Because we have a long history in this country and in most of stigmatizing mental illness, and you can think about dementia as a mental illness. I mean, it is that. It's also a physical illness. It's pretty comprehensive. It's a psychosocial illness and so forth. And not only that, it's become kind of like, what cancer had been. Not that not in any way to diminish cancer. It still can be horrific, but you remember, it's people wouldn't want to talk about it. They whispered about it. And so I think because the advocacy groups like Us Against Alzheimer's, the Alzheimer's Association, the Alzheimer's Foundation, I guess the three largest, have done a lot of education and so forth, but it's still really hard to have this conversation. But it's imperative that you do. And if I can give you one anecdote for us to think about, because these cognitive problems tend to be progressive, if you're a family member and you begin to notice in a loved one that something's changed here, and you're concerned or quite anxious about bringing it up, keep in mind that the longer you wait, the more progressive a condition could be. Even if it isn't dementia, it could be some other thing going on that needs treatment in some way. So, building on the relationship that you already have, if it's a family member, sometimes it's one sibling talking to a parent with the support of all siblings that may be more effective. Sometimes it's everyone together. Gosh, there's just a myriad of ways of doing it, but sensitivity, respect, and dignity should really be kind of where your guidance comes from.
And I think sometimes it is difficult for someone to take that from either their adult child or their spouse. Sometimes the problem is the messenger. I don't know if anybody in here relates to that. So I think, certainly people like me, that's sometimes we're a better messenger because we can kind of come in from the outside. We're coming in with some expertise. It gives us a little bit of street cred. I think care managers too, one of the things that I love about cognitive assessments and talking about mental health and behavioral health and those intersections is that I can do it in your living room, for people who are just really anxious about going to a neurologist, or they don't want to see the neurologist because they don't want the bad news. We can start that process. I've been using the BCAT tools for years, and there is a whole series of tools that look for depression and anxiety, that look at those different domains of cognition, that look at judgment and practical decision making. And I can do it in a non-threatening way in someone's home, and then we can talk about it together. And it just we can spend the time. It takes some of the fear out of it. I always like to frame that conversation around, what are the cognitive strengths as well as the weaknesses? How can we come up with a plan that really plays to the strengths, try to, use the tools that we have available to us to keep what's strong, and look at how do we compensate for some of those areas that are weak. And sometimes having that kind of pre-conversation helps pave the way to get to someone who, a provider, a prescriber, somebody who can, appropriately diagnose and treat. So, and if it's not us, maybe the relationship is with the primary care provider. Maybe
Mhm.
you can put a little whisper in their ear about a conversation that you'd like them to initiate with your loved one. The messenger makes a big difference. Yes.
So what if you're on the other side? So my mom, she would never know or say that she has dementia. She knows she has issues with her memory.
Yeah.
She had a traumatic brain bleed 4 years ago that certainly spurred it, but there were other things going on.
Yeah.
My dad died. She needed to come to be with us, so had a lot of trauma.
Yep.
We've never, I don't, to me, I look at the battery of tests, I'm gonna do them on myself, you know, it's like, but, at, she's 90.
Yeah.
At this stage, the value of, I know just rationally that every stage they have value.
Yeah.
But for her, to go through that type of battery, what is, what are the pluses? What would the pluses and minuses be? We know that she's got a variety of issues, some depression, some
Yeah.
anxiety, some confusion. She doesn't have a diagnosis per se,
Right.
but I'm always trying to balance this element of, okay, what can help her the most? And she always says, "Oh, I'm just stupid," and I'm like, "Mom, no, you're not stupid.
No.
All of your
It's-
connections in your brain just
Yeah.
get tangled up. That's what happens.
People
when we
do
get
that
older."
all the time. They
Yeah.
kind of think that it has something to do with intelligence. I do think that there's value. I think
Yeah.
having a diagnosis, even for very practical reasons, in terms of access to certain kinds of care, it can be important to have a diagnosis. I think also that when you go through that comprehensive workup, what comes out of that is a lot of practical information for how to make things easier, better, more comfortable for her through the end of her life as this progresses. And it will help you to feel more prepared, to know what to expect and how best to support her. So I think that, now this is what Dr. Mansbach is building is something that is unique. This is not, if you go to, a practice to get neuropsych testing, you're usually going to have a student who's going to administer your test. It takes about 4 hours. You'll get a good report, but you're not going to get kind of that contextual wraparound support that Counterpoint offers. Certainly working with a care manager using some of the BCAT tools, it's not anywhere near as comprehensive. We're not medical providers. We can't diagnose or treat, but we can give you some insight using some of those screening tools to kind of where she's at and maybe how best to support her. So I do think there's value. Yes.
Can you have a workup like that done then once they've already started some of the other medications? Because certainly I would think it would affect the outcome and their ability to think with some of these other.
That's a good question. I would say yes, but Dr. Mansbach, for somebody who already has a diagnosis and has already started medication, what is the value of a comprehensive workup?
That's a good question. It may have value, it may not. Usually it has value because we're going to provide, or whoever's going to do this evaluation is going to provide more information. We don't really have an issue if someone's already started on medication or treatment. In fact, we're happy to work with other providers too. The information that we provide is going to be likely more comprehensive, but also more specific. I guess I'm more concerned with two things. Reducing distress or suffering that a person could be experiencing, and optimizing current cognitive functioning. So it's hard to find someone who's going to say, here's where you are in terms of working memory. These are the exercises that you can do, and we'll provide a coach for you if you'd like it, which is something that we try to do. I think it's really important in that respect. I also, if I could, I know there was a question about, you could have a parent who might make, negative self-statements like I'm being stupid or whatever. Or you could have a situation where a person says, well, I'm old already, what's the point of going through, a testing situation or whatever. And I would just say this, if the evaluation can reduce distress, either for the identified patient or for the family, then I think it's worth doing it. We're trying to reduce suffering and optimize well-being. And sometimes you just need more information to be successful at that.
And I want you all to write that down for the family. Everything that we do for people with cognitive impairment, you can't look at that individual in a vacuum. Everything that we do impacts the caregiver. Everything that happens, that experience of your loved one with dementia, I don't need to tell you, impacts the caregiver. And I think it's so important to remember that that your loved one's needs are not more important than your needs. It may feel more urgent, but we all know, and you've all heard it and heard it and heard it. If we don't balance some of that, if you don't care for yourself, your most important role in your loved one's life is that of advocate. That there's always somebody else who can do hands-on care. There's somebody else who can help, build that team. You can build a team of people to support you. But if you aren't caring for yourself enough to advocate, nobody can replace you as an advocate. I'm a professional advocate, but it's not my father, it's not my mother, it's not my husband, so that is your most important role, and you have to do, and it's going to look different for every person. So what you need, whatever it is that you need to take care of yourself, that's okay, and you need to do it. That's my soapbox.
Good, Beyond.
I think we're just about out of time. We got one more question. We'll do one more.
I can't be the only one who doesn't get all of these acronyms and websites. Could you please provide a list of everything?
Yes.
We will. Alex is going to take care of that. A list of resources. I know we've talked about a lot of good ones tonight, and we will get them out to all attendees, so you'll be able to go and peruse. Okay.
Dr. Mansbach, before we say goodbye, thank you for being on this evening. I think I can speak on behalf of everyone for saying you were great. So we really appreciate you taking your time this evening to be with us.
Oh, well, thanks for having me. I mean, I really enjoyed it. One last resource we'll make sure we have on there is that if you go on the enrichvisits.com, do sign up to be a member. Your information isn't shared anywhere. It's just a way of getting educational materials that we send out to people about dementia, about mood functioning, about geriatrics. You can always delete them if they're not of interest to you, but you just might find something that really appeals to you or might really be helpful in some way. So you can just, you can sign up. And if you don't like it, then unsubscribe, down the road. But it is a set of resources that you might benefit from. And
it's good stuff. I'm on that list too. And sometimes something will come up and I'll think, oh gosh, I'm working with a family. It'll kind of hit me, they need this right now. And so as caregivers, you might find something shows up that just is a reminder to do something for yourself. So I think it's a great list. Thanks for reminding us, Dr. Mansbach.
And Heather, thanks for including me. It's great to work with you again. I'm going to say goodbye to everyone now. I hope you have a good evening and look forward to doing this again.
Thank you.
Bye.
Bye.